Good afternoon, everybody. Please try and make your way to your seat. We're going to get started. I am Oluwole Oluwole, Associate Professor of Medicine, Vanderbilt University Medical Center, Nashville, Tennessee. And on behalf of my colleagues who are esteemed experts in the field seated up here, we're going to get started with this presentation, this launch symposium, charting new ground in non-Hodgkin lymphoma, practice changing evidence, real-world experience, and outpatient delivery of cell therapy. So I will introduce briefly Dr. Peter Rydell and Dr. Veronica Barkanova, who are co-presenters with me at this conference. We'd like to say thank you to Peerview Medical College of Wisconsin and the sponsors of this program, BMS, Caribou, Kite Milteney, Novartis, for sponsoring. And of course, please remember to look out for polling during this session. You can also pick up handouts, or you can go to the Peerview site. The link is above to access both the slides from this presentation as well as the handout. So let's do a little baseline poll just to get into the flow. Reflect on your practice and choose the option you find challenging or relevant for the continuing integration of CAR T cell therapy in lymphoma. You want to use CAR T frontline for DLBCL, using for those who are rapidly progressing and thinking about bridging when there are concerns, understanding the future role of faster manufacturing, dual targeting, and allogeneic CARs, the role of CAR T in follicular lymphoma, PUD24, for example, and self-delivery of outpatient therapy. So just scan the QR code and we can start voting. Very good. It's a select all that apply, and most people want to understand the future role of faster manufacturing, which makes sense. And Dr. Redell will give us some of those answers, and the rest of the other questions are totally relevant, and those are the things that we'll be answering at this symposium. So what are the goals for today? We'll talk about CAR T, how it remains a curative option in lymphoma, not just large cell lymphoma. We'll show you the data and some potential hope for promise in the frontline setting. Of course, there are still gaps because many who need CAR T don't get it on time. We'll talk about integration of CAR T into clinical practice, next generation CARs, and the growing body of evidence that supports outpatient delivery and nuances that go with that, because all of those will add to what we do to expand access to for CAR T to all patients that need it. So without further ado, I'll go to my part of this presentation, which is talking about updates on CAR T standards and the real-world experience. So we'll start with a case. I'm a 60-year-old gentleman, frontline DLBCL treated with Ola-R-chip, but subsequently relapsed like as soon as they finished their 6th cycle, they had progressed. Of course, the question comes up, okay, would this be a patient to send for CAR T? How is that going to work? And what if they are frail? So Peter, I'd like to ask you, what's your speech for a patient like this who promptly progressed after 6 cycles of Ola-R-chip?
Well, certainly looking at the patient and his age, and his relatively preserved performance status, I think based on data from the ZUMA-7 and transformed studies, CAR T would be the ultimate destination for this patient, what we would try to get that patient to. Looking at eligibility for CAR T is a little bit different than eligibility for stem cell transplantation, and often we can get patients who may have some comorbidities such as pulmonary comorbidities or even renal through CAR T cell therapy where they may have not been an ideal candidate for stem cell transplant. So I think in this patient's case, that's where I would ultimately angle to get him to.
Thank you. So even in the older patient, for example, that cannot get transplant, or the ones who are really ineligible, although the trials didn't really define eligibility, but regardless, not being able to go for auto transplant does not preclude being able to go for CAR T. Thank you very much. So we'll talk about another case, POD24. Veronica, this one is coming to you. POD24, BR, R squared, progressive disease, good performance status, and not afraid of aggressive therapy. What will you do?
So this is a patient who has a high risk follicular lymphoma, had failed 2 months of therapy, and we don't have an age, but let's say it's somebody who is certainly a good candidate for the CAR-T. I think clearly the CAR-T would be an option, which is one and done with a very promising long term. Now, increasingly, the data are coming of a sustained efficacy and prolonged PFS. So that would be one potential option versus the other, such as bispecifics or the combinations, which are certainly available, but would require a lot more sort of a logistics and a time-consuming efforts from the patient.
Thank you very much.
Big
So
part of the discussion.
absolutely. So even CAR-T, it takes a lot to get it done, but it's still worth it because it probably will give this patient the longest disease-free interval. Thank you very much. So up here now are the approved indications for non-Hodgkin lymphoma. On the left hand of your screen are the indications, and there is a CAR-T for every product listed here. And that is good to know that all of these have approved CAR-T options, and it is good to think about them. So then it brings up a question. Okay, fine. How do you operationalize the oral? You want to give the CAR-T, but you can't just flip it as a switch immediately. It takes some time to get things together, single case agreements. Patient may need to relocate to the transplant center and things like that. So that's why this holding therapy and bridging therapy evolved. And I'm glad that NCCN tried to put this together for us to make it clearer. So on one column, you see the holding therapy. That's what you do before you can do apheresis. And you want to prioritize treatments that are platinum-based because they have activity in the second-line setting. But more importantly, you also want to think about things like radiation to some site, not all the sites where it can be safely done, and most importantly, targeted agents, because they're not going to make that patient sick to the extent that they will not be able to get the care that you intend for them. So then the bridging therapy is different. The calculus at that point is different. You already have all the single case agreement. This patient is already apheresed. So you need to make sure that the lymphoma doesn't take off before the CAR-Ts get back. So you need to think about your turnaround time and then look for a treatment that you can give to them that will not, number one, make them ineligible for CAR because they get too sick or too cytopenic or whatever, or delay the CAR. So you want to choose agents like that so that you want to really preserve the shortest door time for patients to receive their CAR-T. My favorite is involved site radiation therapy, if you can pull it through. Most of the manufacturers are getting CAR-Ts in the United States. We're getting the CAR-Ts back within maybe 12 days, within 17 days, within 20 days. So you can just choose something to hold the disease stable until that time. So regardless of what I just said, what we found out is that not all who require CAR-T are able to get it. And this is really sobering because a real world look at, okay, what exactly is happening? Where are these beautiful CAR-Ts that are approved? Are people actually getting it? It was surprising to see that only about 25% of those who really needed it, they get it at the time that they're supposed to. They do get something, it is just not CAR. It may be potentially something that may be less efficacious, and they may get the CAR in the third or fourth line setting where there's evidence that it may not work as well. So we all need to collectively work harder to make sure that our patients are getting CARs at the time they need to get it. It's even more problematic for patients who maybe have comorbidities or maybe who are older, because as you can see from the first series of graphs, very few or none of them are able to get CAR. So they are being given patient treatment that may not be curative, whereas the curative is there. Then the other one shows that the uptake of CAR has actually been slow since it was approved with the Flatiron database, showing that 2022 to 2024, very few patients are receiving the CAR-T. All right, I want to flip again to, okay, in the real world setting, are people actually doing well when they receive this CAR T? This is a presentation that you will hear on Friday. It shows very clearly that axicell, lysocell patients are getting it. It's being delivered on time. The toxicity management is quite better, or at least same as it was in the clinical trial. And I think it is refreshing to know that it is not because we cannot provide or deliver the CAR T. There are other barriers that are preventing patients being able to access it. Next, I want to talk about this very interesting data of what we call axicell-2. We already know that patients who have very high tumor burden, they don't do as well with the standard one-dose axicell. So some clever investigators say, why don't we do 2 doses for these patients, giving them a second dose day 7 to 14. They were able to pull it off. The patients received their doses with minimal toxicity, 29% with CRS, very manageable. But importantly, it is showing us objective response rates that we haven't demonstrated in patients with high tumor burden before, like 93% objective response rate at 79% CR. The study that kind of showed us that was like Zuma 12, which is much earlier line of therapy. So it is good to see that maybe there is a way that can even the playing field for some of these patients whom we know already have adverse risk. So speaking of Zuma 12, I really like this study. It was patients who did not respond early to R-CHOP or R-EPOCH, but give them CAR after 2 cycles if they are not in at least a metabolic CR. And this data is really mature now, and they showed one of the best outcomes ever for any CAR T. They maintaining their responses, and this is really good after almost 6 years of follow-up, that they've maintained very high response rates, which tells us that this is probably the ceiling, and probably maybe we'll see what happens with Zuma 23. Speaking of Zuma 23, that is a true frontline setting. Remember, Zuma 12 were patients who are selected because they didn't respond early. But it wasn't really a frontline study. This is a true frontline randomized study where patients are randomized to R-CHOP or R-EPOCH versus CAR. It's accruing well, and we are all kind of waiting for this study to report. It is event-driven. Once it reports, and I hope it is positive, it's going to plant axicell in the frontline setting, which will be huge for the field to put some CAR T in the frontline setting. In every instance where it has been tested in earlier lines of therapy, it had always delivered. So let's see how that shows up in the frontline setting. They get randomized and they get the CAR or standard of care, and they are followed on for events. So, having spoken a lot about large cell lymphoma, I want to pivot now to follicular lymphoma. If you look at the guidelines for the treatment of follicular lymphoma in the 3rd line or later setting, you're going to look at, say, 1, 2, 3, 4. Oh, there are 5 possible options. But there are really not 5 possible options. I want to single out the CAR T because the bispecifics, they clearly have activity. We don't know yet whether they are curative. The EZH2 BTK inhibitors and antibody conjugate, we also don't know whether they are curative. So I think in this slide, you can clearly put them into 2 categories. What is probably curative and what is probably palliative. And I think the CAR Ts are really the ones that are likely curative. And why did I say that? I'll show you and I'll prove it to you. Zuma 5, follicular lymphoma. This is very mature because it was the first one. And it's now, patients have been followed up for 60 months. And half of them have not had any progressive disease. Can you think about this? These are people including PUD24. By the time the patient gets to 3rd line in follicular lymphoma, they are refractory. And you are not having them going this far out without progression. I say they are cured. And look at that. That means there's PFS, there's a flattening of the curve. And so this is showing that it is clearly curative therapy. But there is more. Look at the longer-term follow-up of T-cell cells. Similar story. Almost 5 years worth of data, flattening of the curve, and the median OS is so high. So that shows us that these CAR Ts are curative, at least in a fraction of patients in the third line. There's one more. That is one you will hear more about on Friday, which is lysocell. It's not as further along as the other two, but it's also showing really, really good response rates. And that includes many patients with high-risk disease. So my summary is that in follicular lymphoma, we will be able to consider CAR-T as curative, at least in some subsets. So let's take another poll. CD19 CAR-T products are standard of care in DLBCL. Do you now consider them in relapsed refractory follicular? Why or why not? Now choose your single best answer this time. Awesome. Yes, long-term evidence supports CAR-T as standard of care in relapsed follicular lymphoma. I completely agree with that. So my take-home points at the end of this, my part of the talk, is that CAR-T has extended survival in follicular lymphoma, just as it did with CAR-T with large cell lymphoma. Real-world data shows that it is not the optic could be better. Many who are not getting in at the right time, and we need to figure what those barriers are and work harder as the advocates for our patients to get those barriers lifted. So I will now invite Dr. Peter Riedel to come and talk about his insights on the next generation of CAR-Ts. We'll take questions at the end. Thank you very much.
So we'll now jump into some of the new data on next generation CARs, looking at both dual targeting along with some allogeneic CARs and some that we will likely see in the clinical trial arena soon. So I'll first start to kind of couch this session with a patient case. So this is a 62-year-old gentleman with a history of primary refractory diffuse large B-cell lymphoma. He had disease progression within 6 months of completing frontline therapy with R-CHOP. His disease status at this point demonstrates bulky nodal disease with an escalating LDH and B symptoms. There's concerns about his CAR-T eligibility based on his disease control and tolerability of bridging therapy while awaiting cell manufacture. And so I think this brings up some important points to discuss. And so I'll pose the first question to you, Ola. How do you assess whether there's sufficient time to safely proceed to CAR-T versus the need for immediate cytoreduction in your clinic?
So I will assume that we have single case agreement easily on this patient. But I'll be worried, and I think the patient should be worried too, that they have rapidly progressive disease that may not allow time to make any CAR-T, because all the approved CAR-T products at this time, they still require apheresis. There is none approved that is allogeneic. So that said, I will get the motions rapidly, get the patient collected, and I would prefer a product that has the shortest turnaround time. I will also prefer a product that has reliable manufacturing, because this patient may not have a second chance to get a reapheresis. What will I use for bridging? It is tricky because they are completely refractory, right? So I would think about something more targeted, maybe a polatuzumab or some other targeted agent. Or if they happen to express CD30, like some large cell lymphomas, I could use that also. But it's interesting about the AXL2, because if that ever becomes a clinical trial, that may be an option to think about for a patient like this. Thank you.
The higher burden, yes. And so, Veronica, curious on your thoughts. When bridging is required, how do you balance the need for disease control in that patient against the obvious risks of added toxicity with the bridging therapy, the risk of clinical deterioration, and then potential impact on CAR-T outcomes?
Yeah, so this is really the art of the CAR-T and the choice of the bridging therapy. It needs to be individualized. The balance is to avoid prolonged neutropenia, to avoid toxicities which are organ targeting, or just to make patients to be less healthy or less strong. So I do like the idea of a polatuzumab. This patient even get a pola in front line, interesting enough, the polatuzumab duet is not used for salvage therapy, but for our experience in a CAR T community, it actually seems to be quite effective bridging therapy for the pre-CAR T. So I would probably choose that one.
Excellent. And so looking, in the second line space now, we have two FDA-approved products to use. We have both Axicell and Lysocell. So how do factors such as manufacturing time, center experience, and toxicity profile influence your product selection, Ola?
Yes, so it's good to have more than one option. And many times the patient can participate in the decision making. And sometimes we need to kind of do that, but just to get them to the car as quickly as possible.
And so we'll kind of delve into some of the potential role for next generation CAR Ts as we get into some of the upcoming slides. But I think there's at least some intriguing data based on some of that these may be able to move the needle in terms of treating patients who do have a higher burden of disease, those patients that may potentially be at risk for toxicities, or they're concerned about their tolerance of therapy. And I'll get into some of that data in the upcoming slides. So one of the first presentations that I'd like to kind of go over and highlight is actually kind of a novel approach that's, I think, is representative of one of the areas that the field is moving into. And this is based on data from rapcaptogene autoleucel. This is a CD19-directed CAR T-cell product that actually uses the same identical construct as Tc-lec-lucel or Kymriah. However, this is a change in terms of its manufacturing. And so really when they are doing the manufacturing for this agent, they're really culturing the CAR T-cells with the viral vector for less than 48 hours. Which essentially results in a CAR T product that is enriched in naive and stem cell memory T cells that are associated with improved outcomes. And if we look here on the results from that trial, and this was presented back at ASH in 2024, we see among those 63 patients treated an overall response rate of 83%, an encouraging CR rate close to 65%. And for those patients that achieved a complete remission at 3 months, we see that a 1-year PFS of close to 80%. So certainly appears to be moving in the right direction compared to where we are with some of our currently FDA-approved autologous CAR treatments. And I think this agent is also interested in moving up earlier in the treatment paradigm in patients with large cell lymphoma. And so Jason Weston initially presented this data at ASH, and will also be presenting an encore presentation at this meeting looking at rapcaptogene autoleucel in the frontline setting. And so for those that are kind of trying to figure out where this study fits, this is almost an identical study design to the ZUMA 12 trial that took patients that had received 2 cycles of frontline chemoimmunotherapy and had not achieved a complete remission. And then it apheresed those patients. They had bridging therapy if necessary, and then they got their lymphodepleting chemotherapy followed by their rapcaptogene autoleucel infusion, and then were followed for efficacy outcomes, with a primary endpoint in this study being complete response rate. And so we can see, although not very mature follow-up of only 8.5 months at this point, we see impressive overall response rates of close to 90%, CR rates of 74%. Median duration of response has not been reached. And if we look at, just some of the data that we do have at 6 months, for those in complete remission at 3 months, the 6-month PFS rate is very impressive at close to 100%. We're also seeing some improvements in safety as well with these more novel agents. And so when we look at the toxicity profile for this, we see 49% of patients had grade 1 or 2 CRS, with the majority of patients having grade 1, no grade 3 or higher CRS events, and ICANS was also very infrequent with this product, only 8%, with most of those events being grade 1 or 2. And so as we're getting into kind of talking a little bit more about dual targeting CARs, I wanted to kind of provide everyone at least a little bit of a background on nomenclature so we can understand how we're referencing these different CARs. So on the top of the schematic here, we have our bicistronic CARs. And this is essentially a CAR construct that it encodes 2 different CARs on the same cell. So one of those would be targeting one antigen and the other targeting another cancer-associated antigen. In converse, the bispecific CARs, or also known as tandem CARs, encode two CARs on the same chimeric antigen protein that spans the intracellular membrane using just a single vector. And so you can see these are different strategies of potentially targeting multiple antigens. And I'll get into kind of some of the details as we're presenting these trials. So the first that I'll get into is xamtacaptogene autoleucel, or XamtaCell. This is a novel CD20, CD19 directed CAR T therapy, which utilizes the Miltenyi Prodigy platform. You can see on the left side of the schematic here the CAR construct, which utilizes a 4-1BB co-stimulatory domain. And then in terms of the workflow of this trial, patients underwent apheresis, followed by T-cell separation, and then using the Clinimax Prodigy device, those cells got exposed to the viral vector after T-cell activation, transduction, then were expanded with a manufacturing time of 12 days and a median vein-to-vein time of only 13 to 15 days. So patients were able to receive this infusion pretty quickly. And other important aspect I'll note is this was a fresh in, fresh out. And so there was no cryopreservation that was a part of this trial. Looking at this study, this is actually the XamtaCell agent was utilized in a phase 3 trial that was conducted largely in Europe. This is the DALI-2 study that took patients with relapsed refractory large cell lymphoma that had relapsed within 24 months of first-line therapy and were ineligible for an autologous stem cell transplant and had an ECOG of 2 or better. And so patients got randomized on a 1-to-1 basis to XamtaCell or the standard of care, which included either R-GemOx or Pola-BR. Majority of the patients in this study, and for what I'll present, got R-GemOx, and so that's the comparator here. As we look to the data here, we see that really XamtaCell certainly improved progression-free survival and event-free survival versus R-GemOx. And we see certainly a pretty big separation in the curves there, with a median event-free survival of the XamtaCell arm of close to 6 months and nearly 3 months for the R-GemOx arm. And additionally, we saw a pretty impressive safety profile with this, but very infrequent grade 3 or greater cytokine release syndrome at 5%, and ICANS was very rare. And I would draw your attention to the oral abstract that'll be presented on Saturday morning. Now we'll shift to talking about another dual targeting CAR platform. And so this is a study that was initially presented at ASH and will also be presented again at this meeting. And this is really looking at 2 different agents, and I'll kind of go through how they differ. So KITE-363 is a CAR construct. It's a bicistronic CAR. And so this really encodes 2 different CAR constructs on the cell membrane of the T cells. One of these targeting CD19, and that's an identical construct to axi-cell and what we're using in the clinical setting. There's also, as part of that, a CD20 targeting side that utilizes a 4-1BB co-stimulatory domain. And so that is the KITE-363 product. Kite also, as part of their clinical development, explored using that same construct in the setting of rapid manufacturing. And that is the KITE-753 product. And with rapid manufacturing, their aim there, much like was done with the prior Novartis trial, is to preserve naive and stem cell memory T cells in that CAR product while also being able to target more than one antigen. And if we look at some of the results from the KITE-363, that's on the left side of the slide here, we can see that overall this was a pretty impressive activity from this agent. We see here a median duration of complete response of 71% at 12 months. High overall response rate, close to 85%, and CR rate nearly 80%. And additionally, we saw some improvement in the safety profile as well, with no grade 4 or 5 ICANS or CRS. If we look to the rapid manufacturing of that dual targeting CAR, we have our 753 study. And this again was presented at ASH and will again be highlighted here also in Saturday morning's session. We see with that rapid manufacturing that we see an overall response rate of close to 85%, CR rates close to 80%. And many of these complete responses were very early at the 1-month mark. We saw no grade 3 or greater cytokine release syndrome or ICANS at the dose level 3. And so certainly looks to be improvements on both the safety and the efficacy profile with this agent. And additionally, I'll highlight a allogeneic CAR T product. This is, I think, one that's is in the field, one we're kind of excited about. Allogeneic CARs, of course, do try to overcome some of the challenges with autologous CAR T cell therapy, where patients may have exhausted T cells, or they may be lymphopenic from prior therapy, or there may be challenges with collecting patients due to logistics, where something like an allogeneic CAR, something off the shelf, certainly is attractive. And this is a study looking at Vispacel, an allogeneic 19-directed CAR that has some edits in it in order to knock out PD-1 along with the TCR in order to ideally improve persistence of these agents. In this trial, patients underwent conditioning therapy of note with high-dose cyclophosphamide in conjunction with fludarabine, followed by their infusion of the Vispacel agents, and then were followed for outcomes subsequently. From some of the limited data that we do have from the press release, we can see that, although limited follow-up, median of only 6 months in the confirmatory cohort and a year in the optimized cohort, we are seeing high responses and complete responses here. And one thing I'll particularly point your attention to is the 12-month progression-free survival of about 50% in both of these separate cohorts, which I think is arguably an improvement of where we're seeing with some of our other allogeneic constructs, where there is concern about the durability of response with these agents, as they are allogeneic, and often there's immune responses against the CARs, which lead to impaired persistence. And so this will bring us to our next voting question to kind of help close out our session here, or my session. So if we think of a patient with diffuse large B-cell lymphoma who is CAR T eligible and experienced a rapid progression after first-line R-CHOP, assuming there were concerns over toxicity of bridging therapy and all options are available, how might you proceed? I'll give you a moment to scan the QR code, and then we can start voting. All right, so looking at our responses here, majority of us would consider a CAR T product with faster manufacturing. Some of us would consider CAR, bridging with our standard CAR. But I think, if we could certainly limit exposure to additional lines of therapy for those patients, which obviously is associated with risk of toxicity, then that might be the better bet for our patients. And so some of my take-home points here, we see that these next-generation CAR T therapies do have the promise of enhanced activity and durability across various constructs. Dual targeting and these allogeneic strategies do have the promise of addressing things like tumor heterogeneity, where patients may be CD19 negative or lose CD19 or even CD20, and increasing accessibility. These rapid manufacturing and reduced turnaround times may offer clinical advantages, especially in those patients with rapidly progressive disease. And then lastly, I'll highlight that there is some encouraging data with these new platforms. There may be improvements in our safety profile, specifically with the lower rates of severe cytokine release syndrome and neurologic toxicity, which may really promote our ability to give these therapies easier and also as an outpatient. And with that, I will invite up Dr. Bakanova for her session.
Good afternoon, everyone. So we'll move on with our workshop, and my task is to discuss some issues related to the outpatient delivery of the CAR T-cell therapy principles and practical strategies. Do you have a pointer? So we'll start with a question here and a case. This is a 63-year-old man with a early relapse of a CD19 positive large cell lymphoma after frontline R-CHOP chemotherapy. He has a good organ function, has a favorable performance status, has no CNS involvement. He lives close by to the center, has a good, reliable family support, and he wants to avoid prolonged hospitalization. So I'm going to ask Dr. Oluwole the first question, and that is, for this particular case, what are the benefits of receiving CAR T therapy in an outpatient setting?
Thank you. I think it is a very reasonable consideration. Every time outpatient and inpatient had been tested, the quality of life had always been better for patients in the outpatient setting. They sleep better. It's more similar to being at home because they are not in the hospital. Because once a patient is in the hospital, you have to do all these vital signs, you check and so on. Anyway, so yes, I think it is worth exploring. It is not going to be for everybody, but for those who are not opposed and the institution has the infrastructure to make it work, I think it's a very reasonable consideration.
Thank you. And I'm going to ask Dr. Riddle as what is the key outpatient infrastructure component to ensure that patient care will be safe while minimizing hospital time?
So I think there's multiple aspects that are important to ensure that patients can undergo outpatient CAR T safely. I think one of the principal things is education, ensuring that both the patient and the caregiver understand what we're monitoring for, what we're trying to follow, how to call the academic center, how to get in touch with the staff, and then having also sort of a playbook of if a fever develops or if other issues develop. How is that going to be approached? Is it going to be an urgent care setting, an emergency department, and so forth? And then I think the other aspect is when the patient arrives, having the necessary staff there, the ability to infuse tocilizumab or give corticosteroids, do an infectious workup, and so forth. So I think really infrastructure is key, and having the staff and education are sort of the aspects that we highlight at our center.
Yeah, thank you. So these are the issues we will discuss in this session, and including the really protocols and standard procedures which need to be put in place. But I will start with really something we are very familiar with, which is a timeline of the patient CAR T journey, which starts with apheresis, with a potential for the need for the bridging therapy, the delivery of a lymphodepleting chemotherapy in an outpatient setting, followed by the CAR T infusion, and then really predictable toxicities such as CRS and ICANS in the first few days to a couple of weeks after the infusion. And the delivery model of the CAR T has evolved over the last 7 years since we have a CAR T cell therapy, and the initial studies mandated inpatient CAR T administration and inpatient management of the complications. However, the field has evolved and changed, and now many centers are interested in getting the patients outpatient experience with the infusion of the CAR T cell outpatient, including the outpatient management of the complications and developing the infrastructure which is necessary to develop this model. So what can go wrong with this model? Of course, everyone is concerned about delayed recognition of a potentially serious complications. It's all about toxicity. And indeed, early recognition and diagnosis and treatment are critical for optimal outcomes. So we are talking about the ICANS and CRS as really the key toxicities which can become life-threatening if are underdiagnosed. There are other issues such as neutropenic fevers, infections, thrombolysis syndrome, organ compromise, perhaps HLH or mastocyte activation syndrome. These are, some of them are rare, some of them are very familiar to the transplant community, and we are used to manage these complications in an outpatient setting. But management of the CRS and ICANS, it really is a learning curve for the CAR T teams. And so the time to CRS and ICANS vary by the product. This is important because that means that this is really useful to select the product, and it's also predictable toxicity with the procedures which can be developed to really time those supportive care measures to match the time to CRS and ICANS. The good news is that it's universal to all products that onset of CRS and ICANS is exceedingly rare after day 14. So it typically, the time to CRS is anywhere from day 2 to 5, depends on your product, and ICANS is delayed, anywhere from day 2 to 9. And knowing these times is important when you are not only thinking and selecting your product, but developing the outpatient monitoring plan. So another barrier to CAR T can be has been recently addressed, and this is really a mild neurocognitive impairment. These are the patients who may have post-stroke clinical manifestations or are having some other neurocognitive disabilities. And this small retrospective study from a single center has showed that the baseline neurocognitive impairment was not associated with an increased risk of ICANS or CRS, and in fact did not result in any worse PFS on ROS, which has important clinical implication. This is that this really limited neurological reserve should not be a barrier to CAR T, and neither to the outpatient CAR T, as long as the good caregiver is identified. Because we cannot reliably prevent ICANS and CRS, we are trying to identify reliable tools to identify patients at high risk. One of the important tools is a CAR hematotox score. This score uses simple laboratory values related to hematopoietic reserve, ANC, platelet count, and hemoglobin, and baseline state of inflammation manifested by CRP and ferritin. And a composite score of these 5 parameters result in a CAR hematotox score, which is either low or high. And importantly, high hematotox score is associated with increased risk of developing delayed cytopenias, particularly after day 30. These kind of aplastic cytopenias are seen as high as in 40% of patients who have a high hematotox score. This score is certainly important and very useful to identify these patients and manage them prospectively, so we avoid complications or prolonged cytopenias and revert them with some support. So to try to be more precise about identifying the risk factors, there were several studies which retrospectively or prospectively identified the patient-related, disease-related, and CAR T product-related risk factors for the CRS and ICANS. Hematotox score, as I mentioned. Another one is a ASIC score. This is an endothelial injury index, which takes into consideration LDH, and high LDH is a significant factor for increased risk of ICANS. Disease burden, the CD28 costimulatory domain CAR T construct, and the inflammatory markers such as ferritin and CRP. So again, knowing these pre-CAR T parameters is important to and are relevant for the patient selection, for inpatient versus outpatient, and for monitoring frequency and the post-CAR T supportive plan. So we have a growing understanding of infections in general. We know that infections is probably the highest, or it is reliably a highest, in fact, risk for a mortality post-CAR T. The fungal infections are rare, but in a recent meta-analysis showed that fungal infections account for almost 20% of infection-related deaths. And so these findings highlight the importance of ongoing surveillance beyond day 90, and the identification of the patients who are cytopenic with the prolonged neutropenia, who may benefit from the anti-mold, antifungal prophylaxis. The other new predictor of the outcome is the new cell therapy comorbidity index score developed by the multi-center effort here. This new score has involved comorbidities such as diabetes, BMI, pulmonary disease, renal disease, liver disease, with score attributions as you see on this table. And indeed, while the high CTCI score is associated with a slightly higher risk of more mortality, it should not preclude the administration or indications for CAR T-cell therapy. So I'm going to move on to really give you the framework which is necessary to develop an outpatient CAR T program. So this is really a team sport. You need multiple players here to be integrated and communicating very smoothly. It starts with a coordination with a nurse who provides the education for patients, for families, and is the principal key component of the outpatient program. The nurse practitioners are delivering the care. Typically, you need the facility with a daily outpatient clinic capacities. Physician is a leader of the team with not only doing the patient selection and developing the toxicity management plan, but also important in education and patient care. Home care is involved heavily in the outpatient CAR T programs in some centers. And then, of course, nothing is possible without very powerful and strong ties with the family and a family care support. So in terms of the specifics, the components of a successful outpatient CAR T program start with the algorithms and SOPs. They need to be written, they're developed and kept in an accessible place. And these include indications for admissions, the admission workflows, staff education on immune-mediated toxicities. Most centers have a reserved bed availabilities, and this is really linked to a predictable CRS and ICANS timing, knowing the product you are using. This is typically either direct admissions, trying to avoid ERs or other observation beds to allow smooth transition from outpatient to inpatient. We involve electronic medical records to develop treatment plans and flow sheets. Of course, education resources for patient and caregivers, appropriate infrastructure and medical staff with the managing of the AEs, which also include outpatient monitoring protocols and management guidelines. This is also not only for immediate toxicity, but for delayed, particularly for neurotoxicity, which can be delayed non-ICANS or cytopenias and infections. Vaccine recommendations, these typically should be consistent and developed by the center to follow certain data or evidence-driven guidelines. And then, of course, reimbursement, which is typically involved the team which works with the payer coverage for lodging and travel, often provided by the sponsor, sometimes through the institutional support. So here I'm going to show you two really very strong data pieces of administration of the outpatient CAR T-cell therapy from the most recent cohorts. This is a real-world evidence using outpatient lyso-cell, which is reported by the CIBMTR, looking at over 1,000 patients. As you see in this tree plot, the risk for the CRS and ICANS between outpatient and inpatient patients is almost identical. There is no difference in grade 3 cytopenias and no difference in end organ toxicity compromise or other complications, leading to almost identical progression-free survival and overall survival, really suggesting that lyso-cell is one of the products which is very compatible with a safe outpatient administration. The axi-cell can be more controversial. We have two interesting reports here. One is from the single center study looking at 20 patients who received axi-cell in an outpatient setting. And out of 20 patients, 19 were hospitalized, but the median time to hospitalization was 3 days. The inpatient stay was shortened from usual 7 to 9 days to 5 days, and only 2 patients required ICU admissions. The CRS grades were lower, and the median time to CRS was 3 days. So the responses and PFS are remarkable on this study, again suggesting that a very feasible delivery of axi-cell with a strong center with a good support and infrastructure. These data were replicated by the ZUMA-24, which is a multi-center cohort, again using commercial axi-cell in an outpatient setting. and investigated 30 patients who received Axicel. The efficacy data are, again, very meaningful, response rate of 93%. The CRS was predominantly grade 1 to 2, and a grade 3 CRS was low. The neurological events were manageable. There were no high-grade neurological events which will lead to some serious, and there was no increase in mortality. So again, almost all of the patients were hospitalized, 93%, but they were managed with a shorter duration of in-hospital stay. So some promising data on Axicel, although we know that Axicel is associated with the highest risk for the high-grade toxicity. So with this, I am going to move on to the question to poll the audience to see how well you paid attention. So in your opinion, which statement most accurately reflects the real-world safety outcomes of outpatient CAR-T delivery in large B-cell lymphoma? And here are the 4 options, and please scan the QR code here to vote. So we are moving to see the results, and the predominant response is CRS and ICANS are similar to inpatient use, are typically low grade. So that sounds as a true statement. And so here are some take-home messages from my part of the workshop. There's a growing evidence that supports the safety and efficacy of outpatient CAR T-cell therapy, and the risks of CRS and ICANS, as you very favorably pointed out, are not increased in outpatient setting, and the efficacy appear to be identical. Importantly, outpatient CAR T model leads to a fewer days in a hospital. The comorbidities and a mild neurocognitive impairment do not preclude successful CAR T-cell therapy, but extra caution is needed in those patients who develop cytopenias or are at ongoing infection risk. And there are a couple of tools which we can use, and we typically assign this score to every one of the patients who come through the initial counseling. This is a hematox score and an ASIC score, and both of them can inform on risks of complications such as ICANS and toxicities, cytopenias, and can also guide the planning for the outpatient management. And with this, thank you for your attention. I think we are going to move to a Q&A portion.
Thank you very much, Dr. Bakanova and Dr. Adele. We will have time only for maybe 1 or 2 questions because we are short of time. So I think, Peter, there was one question that came up about how to sequence bispecifics and CAR-T. We didn't cover bispecific, of course, this is a CAR-T talk, but how do you sequence that?
Yeah, I think it's a great question, and one I think that's also evolving as we're now incorporating bispecifics earlier into the treatment paradigm. In terms of using both of these treatments, we do know that we can use bispecifics after CAR-T, and that's really one of the areas where bispecifics were first investigated from a clinical trial standpoint. But we've also now, with having them FDA approved, or I'm sorry, NCCN guidelines approved in the combination setting, and then FDA approved in the third-line setting, clinically, we've certainly utilized this in many patients prior to CAR-T, either as holding therapy, as bridging therapy, or even as a destination therapy, with still outcomes I would say mirror some of the clinical trial data. So I think doing bispecific prior to CAR-T does not preclude subsequent CAR-T or the converse as well. One of the things obviously we need to be cognizant of when doing that is to gain more data on does the timing of them in terms of how close to apheresis the patient received the bispecific antibody, does that have any impact on the product characteristics of the CAR-T product? And that's an area where I still think we need to investigate a little bit more closely.
Thank you very much. Dr. Bakanova, there was a question about CAR hematotox and E6. I'm pretty much asking, how do you use it? Do you use it to stratify outpatient or inpatient, or how do you use it in your clinical practice?
Yeah, it's a very practical question. Very practical question. And the way we use it is more to develop a individualized plan. So, for example, we decide about the GCSF administration in these patients earlier than we normally would do. We start the GCSF as soon as maybe 10 days after CAR-T or sometimes earlier. We also plan to use more broad spectrum antifungal therapy for these patients earlier on, especially with a high hematocrit score who can expect to be neutropenic. So it's more of a management and planning for the supportive care. But for the patients with the A6, this is more of a the expectation that the ICANS is more likely to happen and it could be higher grade. And for that score, it really can inform you on whether this is a patient who is suitable for outpatient administration. And so you have additional risk factors such as the CD28 product that makes you be leaning more towards the inpatient administration. So I think we use it for both product selection, patient delivery for the CAR-T cell therapy in terms of outpatient inpatient, plus the management of the toxicities and the prevention of complications.
Thank you very much. So we have somebody at the microphone. You could introduce yourself and ask your question.
Thank you. My name is Matthew Farrow at the University of New Mexico. My question has to do with how you manage patients with renal failure, either on dialysis or just very low kidney function, specifically in respect to how do you dose fludarabine, or do you do it inpatient? And does that impact your CT comorbidity index?
Dr. Reda, you want to answer that?
Sure. I can tackle that one. So at our institution, in patients with impaired creatinine clearance, that would most notably impact our fludarabine dosing. And so we'll sort of, I think for our patients that are not end-stage renal disease and not on dialysis, we'll do the dose reductions as are sort of indicated in the package insert. However, for our patients that are dialysis dependent, we still actually do CAR T cell therapy for those patients. And generally, we're timing the dialysis about 12 hours after the conclusion of the infusion of the fludarabine. And so they'll undergo consecutive dialysis days, generally starting on the first day after the first fludarabine infusion. And there's been several groups that have now published on this, showing that it is can be done safely in this context. And that's kind of also building on some of the data that has been done in by the MGH group that actually looked at doing this in the context of a renal transplant with a coinciding allogeneic stem cell transplant.
Thank you very much. Veronica, you want to ask something?
Yeah, I just have one very small comment, and this is interesting as very much more of a hands-on and a detail, but this matters, and this is particularly for patients who are maybe on outpatient. So dialysis in an inpatient is different from the outpatient dialysis units if they are very much in the community, and that's important to know. Not all the dialysis remove cytokines. And see if you have some patients who in fact has a delayed cytokine release and delayed ICANS because of this issue, and they were outpatients. So this is important to discuss with the hemodialysis unit of what filters do you use. So it really mirrors the inpatient management.
Thank you.
Thank you very much. We are at the or close enough to the hour that we would like to close at this time. Sorry? We think we could take a few more questions then? Sure. Okay, thank you. All right, so there was a question here that says, please provide more detail on why you prioritize speed/reliability of manufacturing over AE profile. So do you prioritize this in older patients as well? I think the question was referring to something that I mentioned that maybe in response to the question also, that you want to prioritize a product that the patient can get quicker. And that is true. So it's one thing to think about a product. It's also another thing to think about AE. So remember, the AE only matter, adverse event side effects. Side effects can only happen if they received a product. So you have to put more weight on the reliability of getting that product and then deal with the AEs. Because if they don't get the product, then the AE is moot. There are times you will not be able to have time for a second collection. That's what I was trying to say. But of course, every patient's condition is different. So there was a question here, Veronica. It says for centers looking to expand outpatient CAR-T, what are the common reasons that patients get hospitalized and how can they think about that in their design?
The most common reason is neutropenic fever. And that is could be neutropenic fever or non-neutropenic fever. We try not to admit non-neutropenic fever and try to manage those patients outpatient. Neutropenic fevers, almost 90% becomes to be a CRS. The patients, of course, have a blood cultures and had a workup for the infections. So the management is antibiotics and a very early on tocilizumab if they have a persistent fevers. So some programs do attempt to manage the fevers outpatient. As I said, it's easier if the patient is not neutropenic. The second most common reason, I think, is some sort of a neurological encephalopathy or cognitive or some suspicious from the ICANS. Those patients exclusively get admitted because the ICANS is very unpredictable, and even though they can respond transiently to in early management, ICANS can progress and can rebound. So we don't feel comfortable. Most centers don't feel comfortable managing ICANS outpatient.
Thank you very much. I think we've come to the final end of the program. Some of us will still be here for a few moments for those that want to chat with us. Otherwise, thank you very much for attending.